Investigations for TB lymphadenitis. And actually, these investigations are done for any TB patient all over the curriculum. In any patient with TB, blood picture should be done. Usually show anemia, leukopenia with relative lymphocytosis. Erythrocyte sedimentation rate is usually high, and it is important for follow-up under antituberculous drugs with decreased erythrocyte sedimentation rate. This means improvement of the patient. When erythrocyte sedimentation rate becomes normal, this means the patient is cured. Brain X-ray chest and abdomen to detect any primary TB focus. Tuberculin test is a good negative test which exclude TB in unimmunized person in non-endemic area and usually not done. Bacteriological examination is very important. Bacteriological examination for the aspirate of the cold abscess or the discharge of a sinus. Bacteriological examination include examination of a film stained with Zell-Nelson stain, culture and sensitivity, and polymerase chain reaction. The most important investigation for TB lymphadenitis and for any lymph node enlargement is lymph node biopsy. What is the treatment of TB lymphadenitis according to the type? Lymph-borne type or blood-borne type? In lymph-borne type, we can divide treatment into two stages: before caseation and after caseation. Before caseation, treatment is mainly medical by antituberculous drugs, at least 2 antituberculous drugs for at least 9 months with good diet, and if needed, sanatorium may be done. Excision of a single group of lymph node may be indicated if no response to medical treatment for 6 months. This is the treatment before caseation. After caseation, that is to say, what is the treatment of cold abscess? Sure, antituberculous drugs with repeated aspiration and injection of streptomycin. The aspiration should avoid introduction of infection and avoid sinus formation. Sure, to avoid secondary infection, the aspiration should be done under complete aseptic condition, complete sterilization. And to avoid sinus formation, the aspiration should be done in non-dependent area. This is the abscess, and this is the dependent area. Never aspiration is done here. Aspirate in non-dependent area. And aspiration should be done in a healthy skin, away from the abscess, in a valvular manner. How? First of all, the needle breaks the skin and then advance the needle in the subcutaneous tissue. Then enter the abscess. How? If this is the skin and this is the cold abscess, we introduce the needle in the skin, then advance the needle in the subcutaneous tissue, then pass deep to enter the abscess, then aspirate. So that the puncture in the skin, not opposite and in the same line with the puncture of the abscess. And if this is the abscess, we tilt the head of the patient to relax the skin. Then pull the skin. Pull the skin so that the healthy skin comes over the abscess. And introduce the needle in the healthy skin. And pass the needle in the subcutaneous tissue. Then enter the abscess and aspirate. This means we introduce the needle in a healthy skin in a valvular manner, the puncture in the skin, not corresponding to the puncture in the abscess. If simply you introduce the needle transversely, puncture in the skin and puncture in the abscess with a track in between, leading to sure fistula is formed. Aspiration should be complete. How you complete evacuate the abscess? Once blood appear. Stop aspirate when blood appear. This means complete evacuation of the caseous material. If filling of the abscess occur, the aspiration should be repeated. This is the routine treatment of cold abscess. Aspiration, and at the end of aspiration, inject streptomycin, repeated once the abscess refills, and the aspiration should be done through healthy skin in valvular manner, and stop aspiration once blood appears. That's mean complete evacuation of the abscess. If secondary infection occur in this cold abscess, if secondary infection occur in this cold abscess, as any abscess, incision and drainage. What is the treatment of TB fistula? Sure medical treatment by antituberculous drugs, streptomycin powder, and dressing. If the sinus is resistant and no response to antituberculous drugs and streptomycin powder, excision of the sinus with the underlying lymph nodes. All this treatment is treatment of caseating type, lymph-borne type of TB lymphadenitis. What is the treatment of blood-borne type, in which there is active TB focus and all lymph nodes are enlarged? Nothing can be done for this patient, only medical treatment by antituberculous drugs and no rule for surgery. This is the TB lymphadenitis. Thank you for good listening and good luck.